Hello there, friends. Welcome to BJJ Meditations. This is BJJ Meditations, episode number 58. I'm your host, Joe Hannon. I have been trying to do what I did in this episode for years, folks. I've been trying to find a dermatologist who trains Jiu Jitsu for years to set the record straight on skincare protocols and best practices, to set the record straight on facility care protocols and practices, to set the record straight on gear care protocol and practices, because there's a lot of mythology that circulates in every locker room in the US, and I'm sure in other countries too, as to what works and what doesn't. For example, is tea tree oil legit? Should we be using distilled white vinegar on our stuff? What is the right way to clean the mats? This is a hotly debated subject even among the team at my school. Well, Dr. Green came on the show, was introduced by our mutual friend Steve Kwan from BJJ Mental Models, and we delved into all these topics and more. Just a little bit about Dr. Green. Dr. Green is a board-certified dermatologist and associate professor of clinical dermatology at University of Rochester Medical Center, and he's also a blue belt where he trains in Rochester, New York. BJJ Meditations, we're all about the examined life via Jiu Jitsu, and the examined life also involves health, which is why I've done episodes on things like my longevity protocols, strength and conditioning routines, stuff like that. I see this as no different. And as you can probably tell in this interview, Dr. Green is a kindred spirit. He also cares very deeply about the examined life, and I'm looking forward to having him back on the show again to talk in greater depth about these things. But I hope you enjoy this interview with Dr. Green. I hope you learn something, and I hope you take something away from our conversation that you can implement in your school to keep yourself and your training partners safe. Without further ado, here is Doc Clayton Green. So I guess my first question for you is, I've been trying for years to connect with a dermatologist to talk about dermatological issues in jiu-jitsu, and
Yeah.
it's hard to find dermatologists who train jiu-jitsu. It's hard to find doctors, physicians who train jiu-jitsu in general. And I wonder if that's because they know better. I'm curious, what your impression is about that.
About train, I don't know. I've thought about this a lot. I started at 40, basically,
Mm-hmm.
training jujitsu, and I think the reason so many adults fall in love with the sport is because it's all these things that, I got the old white dude perspective on this, right? So I'm not excluding the women's experience. I just know my own. But I think all these things that you just don't get as an adult, like playtime, like literally playtime, horseplay with your friends, improvement within a sport, improvement in a sport with other dudes, ritualized combat, which chess, Warhammer 40K, basketball, pickleball, in my mind, those are also ritualized combat. But I think it provides so many things that you just don't get as an adult. And I've been injured several times. It's dumb. But I also see. I don't know why more physicians don't engage in strenuous physical activity, because we see. I see the complications of a sedentary life, and they terrify me. So I will take orthopedic injuries, from time to time over being sedentary. Uh, so yeah, I don't. I only I know only other one. I know a couple other dermatologists who train jujitsu, but one of my former colleagues back in Wisconsin, Ashley Millard, she doesn't train anymore. She's too busy with a child and being a physician. Her husband Nick is I think he's a black belt. I can't remember which gym in Chicago, one of the really big legit gyms, and then one of the other dermatology residents, Devore and Marshfield. He's also they're around, but
Yeah.
no, I don't know why it's not common. I think it's just scary, and most people don't like getting beat up. I was listening to one of your episodes on getting stuck in bottom side control, and who are you, when you're stuck in bottom side control. And I also say as a physician, you're stuck in bottom side control a lot, just in your actual job.
Yeah. Yeah. Especially with the economics of modern medicine and all the business incentives and everything. It's a tough profession. It's changed a lot in my lifetime.
Yeah, and then just coming off the pandemic, I won't get into that, but it's there's a
Yeah.
lot of there are a- you know there are a lot of walking wounded in the with the physicians and the nurses and the PAs and the NPs. It's not been a pretty few years. But yeah, I
Yeah.
don't know. I enjoy the sport. I've got some really good friends, and yeah, I didn't realize that this. Steve talked about how rare back when the Mental Models podcast I did with him last year, how he just finding somebody with this confluence of
Yeah.
knowledge is. So
I've
yeah, I'm
been
happy to share.
I've been searching for years, and prior to what I'm doing now, I was a medical journalist covering. I also did some dental journalism too, covering not only the business side of things, but also the clinical side of things. And I always had my ear to the ground, just like looking
Yeah,
for the right doctor, and I could never find them. So I'm totally stoked that Steve put me in touch with you.
yeah, happy to be on it. I've been watching your podcast. Past few days trying to get a vibe for how the conversation flow goes, and I think you and I have been struggling with a lot of the same stuff and reading a lot of the same books because I've really been enjoying listening to
Oh,
your
thank
episodes
you.
and watching. I was banging out some work today in my office listening to some of your YouTube content. A lot of it resonates.
Well,
So
that's great to hear.
probably hear some of the recurring themes in here when we talk about how do you not get your training partner sick.
Yeah.
You had
Well,
a, there was your school's on my radar though. You had a seminar, I think, in the past 6 months. I really want to do attend. I don't know if you hosted Greg Souders or if you hosted Rob Bernanke, but like you had, I think your school will have one of my bucket list coaches visiting, but I don't know.
I'm trying. The last I want to say big name we had. I can't now. His name is escaping me. He was this Olympic judoka, but we
Travis
haven't had
Stevens,
anybody. Hmm?
Travis Stevens, or
No, it wasn't Travis Stevens. We haven't had. It might not have been us because we haven't had anybody like that come through in a
okay,
little while.
all right.
I wanted to ask you. Oh yeah, what belt are you? Where do you train? I know it's got to be somewhere in the Rochester area.
So I currently train at Synthesis Brazilian Jiu Jitsu. Casey Lamb and Lauren Wolf Lamb are the owners. Casey's the head coach. Another guy my age, 49. They were both Division One wrestlers, and Casey retired from wrestling and then got back into grappling sort of in his adulthood, and ultimately became a black belt as a Hudson Mara affiliate school. It is a fantastic gym. He's a dear friend, first friend I made here when I moved, and I'm a four stripe blue belt.
Right
Getting
on the
close to.
cusp.
Well, the objective reality in the gym where I train is the purple belts are really fucking good, and the as a professional educator, I'm a little embarrassed. I've been training. I've got a lot of mat time and just slow grinding progress, but
That's
it's
the blue belt. That's the
yeah,
story of the blue belt, and I think that's why so many drop at blue. So I don't think that's unique to you. I think I remember going through the same exact thing. Blue belt was the hardest belt for me.
yeah. But I'm having a lot of fun. I have a lot of really good training partners, and I really value, even though I there's a I give them a lot of shit for beating me up. I actually value having training in such a good room. And
Yeah.
Casey's a dear friend, just a good dude. Great vibe, great culture. I started in central Wisconsin. I was in a town called Marshfield for 10 years, and it's a small town, about 18,000 in central Wisconsin, about 3 hours from a big city. And I was starting out in Aikido school. Jason Tucker, a good buddy, started. And then another good friend, Cody Stry, realized we had mats there, and he was a Jiu-Jitsu blue belt who was driving about 40 miles to train, and he just approached Jason and said, "Hey, can I do a grappling night?" And so Cody sort of came and started doing Jiu-Jitsu and there, and so then that's when I've always loved grappling. First time I did any grappling, I was in an NSF-funded science camp in high school in Pennsylvania. I grew up in Western Kentucky. There was no wrestling. I mean, people didn't even know wrestling existed.
Wow.
They thought Hulk Hogan, right? If you didn't play football, you weren't an athlete. And so one of the kids I met there, Johnny Six, was a pretty solid high school wrestler in Pennsylvania, which has always had a gnarly wrestling culture. And he asked me if I wanted to wrestle, and I'd been in a bunch of fistfights because that was just like normal in Kentucky in the '80s. And I was like, "Oh yeah, sure." And he just ragdolled me. I had never, ever been just ragdolled like that in my life. I was like, "Man, I gotta learn to do this." And so yeah, then 40, I finally have a chance to start. Okay, let's do this. So Cody Cody brought Brazilian Jiu-Jitsu to Marshfield, and then about 2 years into that, he got bored of Jiu-Jitsu, and we became a judo school. So I got to start learning judo in my 40s, and so my guard kind of plateaued, and I got better at judo. But then that's a lot of fun, and at 42, 43, you start learning judo, and then the pandemic blew up, and we had a distance, and my training was limited to Preet Mikkelson's defensive BJJ stuff in my basement with my son, and so I got that got me through my grappling training in the pandemic. So there's been lots of fits and starts and changes in emphasis in how I train. So when we moved to Rochester and things finally opened up, I was able to start training pretty consistently with Casey and those Savage synthesis. So
That's great. It's interesting because I'm thinking of a lot of the people who are sort of in your age cohort who are at our school, and a lot of them have had similar patterns. Like they had an early introduction, and then there was a huge gap because life intervened. For you, I'm sure your medical training took up a big part of your time, family. I think, you mentioned you had a son just now, but they come back to it. Like it gets its hooks in you, and it's the power of it is undeniable, and it's so undeniable that years go by and you come back. Like I can think of like 3 or 4 people who have a similar trajectory as yours.
Yep. So I'm glad it's there for me. The closest thing it reminds me of is the first thing I wasn't really, I'm a decently confident athlete, but I was not really an athletic kid. I didn't like football. I wasn't from a sports family, and I didn't realize I was athletic until I discovered skateboarding in like 1987. My older cool cousins, D in St. Louis, got a skateboard, and I always idolized D because he was the first person I met and remains to this day one of the coolest people I know. And that effortless cool, and D started skateboarding. I got heavily into skateboarding and got good at skateboarding. And then it had Jiu-Jitsu has that same vibe. It's kind of a bit of a fringe sport. You tend to have misfits and that concentrate there, and you instantly make friends. Like, oh, you train, and you can tell the look. Like you can always tell the look of the skaters from the late 80s. If you're in another town, you know who the skaters were. It's like if you know what to look for, you can tell who the grapplers are.
Yeah.
And so it fills that role of just fun and just horseplay with friends.
I could totally relate to that. When I was traveling around the country covering medical conferences, wherever I went, people would look at my ears and be like, "Hey, you train jiu-jitsu?" And then immediately it would be like, "We're having an open mat tonight on the other side of town. Like, do you want to come?" And you just made friends. I made friends wherever I went. It was wonderful. It was like having a friend in every city in America.
Yep.
So, I mean, the big reason I wanted to reach out to you is I have this background in medical and scientific journalism, and I hear so much stuff circulating in jiu-jitsu and other combat sports about skincare, and I know my way around a clinical study. I know my way around asking questions of legitimate healthcare providers, and I hear so much what I think is bad information or incomplete information, and I'm a really big believer in giving people good information to make informed decisions. So that's kind of, I wanted to just take that approach with you today. Talk about the landscape of these are the diseases that you have to worry about, and then get into sort of what are the protocols to maintain skin health? What are the, if a thing should rise to a level where it needs clinical intervention, what are the common pathways people are going to pursue? So I would love to kind of walk down that path a little bit for you, just kind of starting out with in your mind, as somebody who is a grappler and happens to be a dermatologist, what are sort of the big conditions that you need to be, or diseases that you kind of need to have in mind for your own health and safety and that of your training partners?
So I'll work through the infections, kind of from potentially most serious to the least serious or annoying. People worry about Staph aureus, and Staph has a lot of names. We can go into more detail on that. And that one can range from a superficial aggravating skin condition to, life-threatening, overwhelming blood infection and death. The next one that can also cause pretty significant infections are the cold sores, the herpes simplex virus type 1. That is very common. You most commonly see cold sores in the lip, but if most people pick this up, sometime in adolescence, and your first outbreak in lips is pretty god awful, and then it goes away, and then you have maybe a mild nuisance infection that recurs once, twice a year sometimes. The problem with a cold sore virus is the longer you go before you catch it, you tend to have a worse infection. And
Interesting. It's kind of
get
like
it
shingles or varicella
exactly
zoster,
like chickenpox. Yeah, like
chickenpox.
chicken. An adult, a child is a nuisance. As an adult, it'll kill you. But HSV1, you can get if you somehow dodge HSV1 until adulthood, and you're grappling, and your teammate has a mild cold sore, don't think much about. You're smashing your face against them with skin
Yeah,
contact. You can get a recurrent herpes infection kind of anywhere in the head and neck where that thing takes hold, and you can get eye involvement. You can get face, neck involvement. It's called herpes gladiatorum, and you could
that's
have a
really interesting. I don't think most people even. This is the first time I'm hearing about that, so that's very fascinating.
yeah, and it tends to recur in the same location.
Okay.
But yeah, HSV1, herpes simplex 1, cold sores is a distant cousin to shingles virus, varicella zoster. It's also a distant cousin to the genital herpes viruses. But it's painful group blisters that we see with that. So that one you really shouldn't train with a cold sore just because you could. Most people have been exposed, but
Yeah.
if your training partner hasn't had a cold sore, they can get a pretty god awful infection somewhere in the general area you're grinding your face against theirs.
Add that to the list of conditions to police for gym owners.
And then you got ringworm, and ringworm is very common. It's almost an occupational hazard,
Yeah.
and that's a fungus. We can talk more about the new reason. There's nuance to the drug resistance conversation, and then there's some over-the-counter products that probably steer everybody away from to not make that worse. But this is one that it's not. If I looked, I'm sure I could find case reports of people dying of ringworm, but it's typically a superficial skin, hair, and nail infection, but it doesn't go away on its own. It can be pretty extensive and god awful and icky. A couple other viral infections. There's molluscum contagiosum.
I have had that. Didn't know about that one until I had that one.
Guess what? You have lifelong immunity now.
Yeah.
So molluscum is kind of the annoying, icky, least serious version of these things. They're little belly button shaped pink bumps, and they show up in skin contact. Grapplers can be your face and forearm.
Grapplers and kids in daycare, right?
And college kids and people engaging in, making new sexual partners. It can show up as an STI. If I see it in the bathing trunk region of a college kid, you got to screen for other sexually transmitted infections. But if you get it on your face from Jiu Jitsu, it's not an STI. But that one, once again, immunologically competent people, you might have a very mild infection, you might have a very extensive infection. Pretty much when I have wrestlers that have that, it's the least restrictive of all the infections to compete with. But basically, most wrestling governing bodies, if I just scrape the lesions off with a curette and put Band-Aids on them, they can compete. The natural history for molluscum contagiosum, at some point, your immune system finds these little devils. They melt away spontaneously. They leave little dimples temporarily. And it's lifelong immunity. So pox viruses are actually really cool. They have massive genomes full of things that mimic our immune system to kind of trick your body into not finding it. But they're also large and structurally complex. There's a lot of things your immune system can react to. So molluscum's lifelong immunity. And there's warts. Warts are people train with warts. Warts are human papillomavirus, and there's about 80, 85, 90. I don't know what the count is for different strains of wart viruses. There's the handful that cause genital warts. These are different from the ones you get in your hands and feet. And so if you're giving your training partners genital warts, it's probably not from normal grappling. And then, but like the hand warts, they're contagious, but they're variably contagious. Some people are more prone to warts than others, and some people never get them. It's frustrating. There's a lot we don't know about warts. They're small viruses. I think they have 7 or 8 genes in their DNA genome. We can't culture the darn things in vitro. So a lot of what we know about warts is kind of indirect stuff. But, these are the ones where I think most people don't get too bent out about plantar warts or palmar warts. They are contagious, sort of. But those are the ones which are most serious to, I'd say molluscum's the least serious. If you ask someone who's immunosuppressed or has bad eczema, they can have pretty god-awful extensive molluscum infections. You still manage it the same way, scrape them off. But If you have molluscum, it's better if you just go see the doc, get them scraped off or frozen, get rid of them before, and keep the little spots covered and go train.
So let's talk a bit about staph because, signs and symptoms wise, molluscum, you covered that. Ringworm, I think we'll get more depth into ringworm in a bit, but I think most people know what that is. Um, Warts too. I think pretty much as everybody's had a wart or two at one point or another. But I feel like staph is kind of a sleeper because I'm one of those people who's prone to staph infections despite being super meticulous with my skincare and my hygiene and everything. And I've gotten so good at spotting the early signs of a staph infection that like I know what it is. I go to my primary care provider instantly and I get the medication I need to clear it up. But I think a lot of people play this little game where they're like, is it an ingrown hair? Is it a pimple? And then anecdotally speaking, like I think that's when these infections can kind of become more serious than they might have been. So what should people be looking out for a staph infection in particular? And like, what should they do when they suspect they have a staph infection?
Okay, so a staph infection that you acquire grappling is going to be in exposed skin where you are in contact with people. So if you're a pure gi, it's going to be head and neck, back of your head. If you are no gi, it's going to be forearms, legs. It's going to be exposed skin, and so where staph lives in most people is it colonizes the anterior part of the nose, the armpits, the groin, the butt crack. About, I don't know, anywhere between 10% of people just staph aureus, the one that actually causes the infections, is normal flora in just a
Yeah.
small percent of the population. They never get sick. And so if you think about, okay, where is there a part of my body that's like maybe touching someone's nose or face? Probably not their butt crack or anything grappling. I mean, who knows how you put it. It's like, it's going to be in your volar forearm, this kind of thing, maybe back of your leg from, triangling someone's face. It likes folds typically, but the morphology of the primary lesion can vary. Impetigo can be just a little crusted plaque.
Yeah.
But they're always symptomatic. They hurt, they sting, they itch. They're not something it's there, but it
Yeah.
can
It
be
looks, and it looks wrong when you see
yeah,
it.
raw and irritated. There's almost always a honey colored crust, a golden colored crust. Staph gets its name. All the microbes, every species of critter has a first and last name, the binomial nomenclature. Aureus means gold. If you grow these things in blood agar plates, they make kind of a gold pigment. And so, but their honey crust can be kind of golden too. So it's a very distinctive looking, raw, irritated, crusty thing. It's pretty common to have, a swollen lymph node in the area you have the actual primary lesion. So the impetigo, and then you can have superficial blisters. This is called bullous impetigo. That's a specific flavor of staph that has a protein toxin that causes shallow blisters. Could be bullous, could be a little non-healing patch of honey-crusted eczema-looking stuff. It can be a pustule. The difference in an ingrown hair and a staph pustule, it's a different strain of staph that causes the pustules, and that's usually a community-acquired MRSA. MRSA stands for methicillin-resistant staph aureus. Methicillin's an antibiotic. Community MRSA is different from hospital MRSA, but the community MRSA often is pretty famous for god-awful pustular infections. I mean, if you have one or two inflamed hair follicles or acne bumps in a covered area, I don't get too bent out of shape about those. If you've got like a solitary kind of painful, raw, irritated thing, and you don't normally get these, and they're in an area where you're likely to have been in contact with someone else grappling, you need to think about staph. And most people in the U.S. with, we could touch on this later. You asked me what keeps me up at night. Access to healthcare keeps me up at night. It's an area of, it's what I actually do for my academic research, trying to figure out how to optimize derm access.
Yeah.
But most people, the problem with the grappling world is most of these people who engage in jiu-jitsu, they're young, healthy people. They may not have a primary care doc. So if you got a primary care doc, family practice, internal medicine, these people have a solid hand on managing outpatient staph infections in the young healthy. So if you have a primary care doc, go see your primary care doc. If you don't have a primary care doc, which is pretty common for the 20-somethings, your point of contact is going to be urgent care. And same thing with urgent care. A lot of them have a decent handle on picking, on recognizing a staph infection.
Yeah.
And your going to have to just bite the bullet and be on a 7 to 10 day course of oral antibiotics to get it gone, right? And that's basically staph. It is you know you have it, right? Like my knucklehead oldest son, he'll be 20 in April. He was pretty solid wrestler, and knucklehead. He competed in a tournament, and at the end of the tournament, he's like, "Dad, the ref looked at this and let me wrestle. I got this raw spot in the back of my head." I'm like, "Jesus Christ, son, this fucking staph." But it was small. It was like quarter sized and raw and irritated. But I mean, to me, it was obvious. And I have cautions. Like, look, the coaches, like, I'm a youth wrestling coach. Like, if you show me a rash, the kid's probably gonna get benched because it's like,
yeah.
So because it's probably not always contagious. There are like one of the main textbooks for dermatology field is written by Jean Bologna, who I think is at Yale, but it's like 2 giant encyclopedias of stuff that's not infectious. A lot of rashes that aren't contagious, but the ones that are, like, the wrestlers, all the local wrestling coaches are pretty darn good at, a lot of them train at Synthesis, and great bunch of guys and some women, but they're all pretty good at recognizing staph or ringworm because it's a common thing.
Yeah. So just to underscore that, so active staph infection, like, that's a no-fly zone condition. Like, you should not be training until the full course of antibiotics has run, or what's the clinical guidance there if you have an active infection?
It's going to vary a bit by state. I'd have to. I don't have it off. I don't remember off the top of my head. There's every state wrestling governing body has a skin check form, and they have return to sport guidelines for infections and staph infections. It's I think it's 72 hours of antibiotics and no new lesions, and all lesions are crusted.
Got it.
But if you're a gym owner and you're anywhere in the U.S. and you have questions about this, you can look up. New York State's got a skin check form. Wisconsin's got a skin check form that tells you when your people can go back to compete. When wrestlers are obsessed with competing, it's just in the culture of the sport. But for recreational grapplers, it's not that big a deal if you want to ultimately be on the safe side, don't train until you're through with the antibiotic. And here's the other challenge of treating staph infections. What ideally happens when someone sees you and they're pretty certain it's a staph infection, you have to look at that and make a decision on what's called empiric antibiotic treatment. You look at this and say, okay, this is staph, they need antibiotics based on allergies, other medications might be on, community profiles of resistance genes. You pick an antibiotic and you do empiric therapy, meaning you're giving an antibiotic without knowing sensitivities. What they really should be doing as well is swabbing your staph infection, or if it's a pustule, pop it, that lands it, and then collect pus and culture it. And then you get something called culture and sensitivity from the clinical laboratory. Staph grows very easily, and this is a common enough thing. You have an answer about 24 hours if it's Staph aureus or not, and then about 36, 48 hours, you'll have something called, the lab will report antibiotic sensitivities. So it'll tell you, okay, if the doxycycline works in the strain, if the cephalexin works in the strain.
Yeah.
And so
that avoids the guessing and checking and contributing to antibiotic resistance.
You have to guess initially, but you need to follow up on the results with either, hey, we picked the right drug, you're good, or the strain's resistant to the cephalexin, you need doxy, or less commonly Bactrim or clindamycin. So I think it's nice about waiting at least 72 hours is you should hear back if the organism you're being treated for is susceptible to the antibiotic that's given. So I would say 72 hours after the antibiotic is the right antibiotic, and no other addition, no new lesions or older lesions are crusted. That's a pretty handy clinical marker of your responding to the antibiotic. So I've actually been working closely with urgent care here in my organization to get them better at dermatology, because we don't have a call service that supports our urgent care systems for derm, and they see a lot of derm. And
yeah,
it's kind
most
of
the time I've gone to urgent care for derm issues, and they've just kind of they haven't done a culture. They've thrown whatever the clinical guidance suggests at it, and it's been effective. But based on what you're saying, it's like it sounds like there's a much more precise way to go about this, and safer
it's literally
way.
just It's literally just a swab. And the challenge of this too, one of the things you asked, what keeps me up at night, the physician shortage.
Mm-hmm.
And when physicians, there's a nursing shortage we're all dealing with right now and trying to figure out how to deal with. There's also a physician shortage, and the problem is like when physicians break, we break spectacularly. And so that's the thing that kind of scares me. It's like, okay, what happens when the physician shortage really starts to kind of blow things up? And urgent care provides a really, I think, a useful service, but they're having to figure out, okay, what do you do if the patient doesn't get better? So they don't have as they don't have as good of a shift work, so they're having to compensate more and more with the young healthy people and the primary care doctor shortage. So I think they're delivering more urgent primary care to like young healthy folks, and so they're having to build more systems into the continuity of care, which I don't think was ever exactly intended for urgent care. But if you know a primary care doc and now you're back and what they diagnosed impetigo is not better 2 weeks later, well, now you have to figure out, okay, I need to culture this. Or sometimes I've been working closely with urgent care in my organization, trying to get them better at derm and help them with derm. They're very receptive, and it's good because we cannot deliver all the derm care that this region needs.
Yeah.
So,
and I imagine that's a common problem. Like here in the Northeast, it's very easy for us to forget how big the country is and how you could live in a place where the nearest dermatologist is a 2-hour drive away.
Yeah, and when I was practicing at the Marshfield Clinic, it was a rural tertiary care healthcare system. It was an amazing place. It did so many cool, forward-thinking things. But I had people who, they'd come 3 hours. They were in the Upper Peninsula, Michigan. They were literally 3 hours away from me. So I had to figure out. I mean, what was nice was the Marshfield's healthcare network, their labs and primary care clinic sites mapped pretty well to these people, even though they were far away from the tertiary care center. They were the satellites matched the geography well, so I could order them labs. Their primary care doc was close by, so there was a lot more of a safety net delivering specialty care. One of the challenging things I'm running into in upstate New York is the healthcare systems have narrower regions of narrower catchment areas, but University of Rochester is the only tertiary care derm department upstate. Buffalo Medical Services doesn't have derm department, and Syracuse doesn't have one. Albany doesn't have one. These larger regions that still take a big chunk of the state don't have derm, so people might come to see us with bad stuff, and they're from 4 hours away, and we have no lab center for them done. So we're trying to manage, really god awful stuff. It's much more difficult when your laboratory and primary care imprint doesn't match the geography of your organization. Upstate New York has like 6.7 million people or something.
Yeah.
So more of the shit that keeps me up at night.
Yeah, it's much bigger than the microbes, and I think that's like what a lot of people don't realize is like this is a systemic problem.
Oh God, it is. But this, that's a problem. I mean, some of the studies that we're doing, I'm looking at a year of urgent. Can I talk about, do you want to hear about this stuff? Or do you want to stick to the microbes?
I mean, I want to go where the conversation goes. I'll say this. I only budgeted an hour for the conversation, so I'm already, and I have another meeting after this, but I'm already thinking maybe we should do part 2 at some point, if you're amenable to it.
I can probably talk for now, but the problem is like specialty care is challenging, and people who aren't specialists get such a broad spectrum of specialty care experience. And this is where I think derm is failing primary care, derm is failing urgent care. Like we don't train them well. And I've been clerkship director for the dermatology rotation when I was in Marshfield. I filled that role for 9 years. I did it for about 2 years here at U of R. And just like, we don't train them well, but I'm figuring out ways. I think I figured out a new way to help them that's actually much more effective than shadowing me for a week. So
that's great.
Hopefully I can make urgent care better at derm. Everybody wants to get better at derm. It's just all right. So we can talk to the stuff that the grapplers want to hear about.
Yeah. So I'm curious, like what are your skincare protocols? Because I hear all kinds of wacky shit, which may or may not be validated. Like people are enamored with tea tree oil. People are enamored with white distilled vinegar. What are you doing to take care of your skin? What soaps, shampoos, stuff like that are you using? What detergents are you using for your gis? Like, let's talk about the boring but important shit.
So Tea tree oil is not bullshit as a maintenance measure. There are tea tree oil body washes at 5% concentrations do seem under controlled, under like small clinical trials. 5% tea tree oil washes do appear to perform as well as chlorhexidine, for example, in reducing staph colonization
That's
in the
wonderful.
armpits and groin. You can't get you can't get tea tree oil decolonizing the nose. The concentrations required are just too irritating. But like, does tea tree oil kill staph? Absolutely, well validated in laboratory experience. And does it kill it on you? Yes, there are some studies to support that tea tree oil soaps, if you like them, use them. Do we know if it works? Do we have tea tree oil studies comparing it against like Dove bar soap or Lever or Crest or whatever? No, we don't. The most important thing to do after you train is go take a shower. And if you don't know how to use soap, make a big lather and get it everywhere. Like, you should be lathered everywhere. And if you're worried about staph, get your armpits, your groin, your butt crack, and just rinse it off with warm water. Soap doesn't have to be antibacterial. Soap works by busting these things loose and reducing the numbers on your skin. You've probably seen the engineering diagram, all the Swiss cheese, and then you twist them all so you have all the holes covered. That's your approaches to reducing skin infection. So I don't have strong preferences what people wash with. Defense. Can I name brand names in your?
Oh, absolutely. I don't. Yeah, we're not sponsored by anything or anyone. So, what products do you like?
I use Dove Bar because most dermatologists, we love Dove Sensitive Skin, the bar, because it is one of the gentlest soaps in the market. And we spend so much time trying to like help people not irritate their skin that we steer people towards Dove because it's a gentle soap. It doesn't irritate them. But that's what I use Dove. I use Dove bar soap, and I wash my hair and beard with whatever I have handy. I'm just like most men. I use what my wife buys. It smells good. Like, it doesn't appear to matter. Just wash after the dude in me. I use what my wife buys. The dermatologist in me, I like Dove bar because it's gentle. Lever in the bar, or Lever if you're Canadian, it's a gentle soap. Caress is a nice gentle soap. But if you like, some of this approach, I think about like James Clear's habit, like make it easy, make it attractive. If you like defense, if you feel good about using a tea tree oil because John Danaher recommends it, like, fine, do it, just wash. But yeah, no, tea tree oil is not bullshit. It's a real anti-staph thing. I just can't tell you if it performs better than any soap. And
Sure,
daily showering after I'd say it's far more important for you to shower after you train with a soap and warm water than I would say. I would say don't think you have to use a tea tree oil product, but no, it's legit. I would definitely recommend you don't treat an active staph infection with tea tree oil. Take the antibiotic. If you want to use tea tree oil on the side as maybe something to reduce colonization, fine. But I would say don't skip your Cephalexin or Doxy to use tea tree oil to treat a staph infection. I have sensitive skin. I have a mild eczema. I tend to moisturize in the winter after my shower. Derm is always telling folks to moisturize their skin, and because if your skin's well moisturized, well taken care of, it tends to be more durable and less prone to problems. The correct way to moisturize is immediately after the shower when your skin's still damp, because at that point your stratum corneum is fully hydrated, and you think of moisturizer as a sealant. For derm, the greasier the better. Like, for babies, we recommend Vaseline, but most adults don't like the texture of Vaseline. Once again, pick the product that feels good in your skin. Things you scoop that are fragrance-free, we tend to like better. Vanicream makes a really nice pump product. The CeraVe in the tub is lovely stuff, but if you like Jergens, Vaseline, Intensive Care, Eucerin, they're all good. Just pick the one you like, and after you wash soap and water with a gentle soap or tea tree oil soap, moisturize. I would say also, I can't find when I was doing the background work for eradicating germs from fabrics, for the mental models episode, it was 198. Make sure the most important thing to do with a gi, stuff does hide in fabrics.
Yeah.
Wash it in the washing machine. Doesn't really appear to matter what detergent you use. You just have to make sure that you're using the right amount per the wash, so the concentration's right. And you have to make sure that you are washing with a temperature that matches the detergent. The detergents are optimized for certain wash temperatures. So you just got to make sure that those things match, and then you really should throw your things in the dryer. Under experimental condition, eradicating ringworm and staph, like eradicating staph from fabric is a long, problem for hospitals and institutions. You concentrate sick people, they get more staph, but and then kennels, for example, animals have ringworm, and so kennels have to deal with not sending people's pets home with ringworm, and so eradicating ringworm from fabric is the same thing. But like washing with detergent is not adequate to fully eradicate these things from your gi. You need to throw them in the dryer too. Don't UV light's a powerful surface disinfectant, but it doesn't disinfect fabric. It doesn't penetrate deep enough. So just wash them pick the detergent you like the smell of, or the price of, or the packaging fits your environmental values. Read the label. Make sure you're washing your fabric in the temperature range it recommends, and the amount of water volume to soap volume recommends, and then throw it in the dryer, and that's going to reduce things enough that things you're circling another. You're twisting the Swiss cheese to block the hole.
Yeah. So it's right concentration, right temperature. Put it in the dryer. Those are the big things. Yeah.
Correct.
Good to know. Let's talk a bit about ringworm, just because it's top of mind for me, just because I don't know what's going on in my school, but we run a very clean ship. The mats get cleaned multiple times a day. But for the past couple months, we just have this persistent creep of ringworm. It comes and goes in waves. So we're instituting all these new protocols and stuff to try and get it under control. But, what caught my attention, it was the CDC alert that there's this emergence potentially of resistant ringworm. And I was thinking oh, maybe this is what it is, because we're having a hard time getting a hand on it. But as you mentioned at the top of the hour here, there's some nuance to that conversation. So let's talk a bit about ringworm in jiu-jitsu. What's the best way to manage it from a personal hygiene standpoint and medical standpoint? What's the best way to manage it from a cleanliness of the facility standpoint and a, let's say, protocol standpoint? For example, how long should you stay off the mats if you have a confirmed case of ringworm, and when is it safe to come back?
Yeah. So the skincare is for reducing chances of acquiring a ringworm infection is the same as for staph. Shower immediately after you train, and all your stuff gets thrown in the washer with optimized for your detergent, and then thrown in the dryer. Under experimental conditions, you can eradicate ringworm from inoculated fabric with those measures. So if you're putting a pure culture of ringworm fungus into a gauze, and this is a much higher density of stuff than you're going to get probably exposed to just rolling around. But the hygiene measures are the same. A lot of the wrestlers swear by selenium sulfide-based shampoos. Selsun Blue is an example, and so, but I don't. It's an interesting idea, because when I look at that, when I looked for the original study on this, what I actually found was ringworm. You can get ringworm in the scalp. It's called tinea capitis, and that always needs oral antifungals to treat. You can't eradicate that topically. But what there's a decent quality study out there found that if people who are on systemic antifungal therapy that are washing with selenium sulfate-based shampoos, it shortens the duration of systemic therapy need by about a month. So once again, indirect evidence that may be beneficial. We don't know if washing with this has preventative benefit, but it's a thought. Your folks could all think about washing. They're washing their bodies with selenium sulfate-based shampoos. I think with mat disinfectants, if the commercial mat disinfectants, you look on the bottle, they should say hospital grade, intermediate level, surface disinfectant, and it should list the organisms it kills on the bottle. The ones you care about as a gym owner, you care about, and what it says varies, right? Sometimes it says ringworm kills AIDS, doesn't kill AIDS. AIDS is what happens when your T cells drop below 200 when you have HIV. AIDS is not the virus. AIDS is a condition when you're really sick at the end stage of the virus. HIV is the virus. But dermatophytes is the group of fungus that causes ringworm, and the three genera you care about are trichophyton, microsporum, and epidermophyton. So, like, you want to make sure, read your bottles. Does it kill these things? Yes. You want to make sure it's diluted correctly. So read the instructions. Make sure, is it spray on out of the bottle, or do you have to mix it to get the concentration right? Look at the contact time, right? It should tell you what the contact time is. But all the commercial mat disinfectants should do the job. What I would warn everybody, though, you definitely need to sweep up your mat first.
Yeah, that's a big one.
Yeah, hair and nails and fuzz, you can't decontaminate that easily with contact disinfection. And ringworm does. These ringworm fungi are unique, and they eat keratin, which is a structural protein of our skin, hair, and nails. And so, if the darn things could be hanging out, nails fall off or things like that. So sweep all that up and get it off the mat, and then spray the whole mat down generously. And then once the whole mat's been sprayed down, someone comes up and mops it up. But the thing about ringworm, there are, once again, look on the. I should have looked this up, knowing you're a journalist. I think it's 3 days of treatment, topical or oral, for ringworm, and no new lesions, and old lesions are crusted before you can compete. But if you look up skin check form, wrestling skin check form for your state, that'll tell you the restrictions on when people can come back with a ringworm infection. Now, the thing about ringworm, if you treat topically, there's over-the-counter agents, butenofin, terbinafine work well, and over-the-counter agents, azoles, also typically work well. Ringworm should be improving in, it might take 5-7 days of treatment to get it to improve, and it might take a full 2 to 4 weeks to get completely gone with topical therapy. So people might not be treating long enough. One of the problems I'm combating in trying to get urgent care and primary care better at derm is there's a product out there called Lotrasone, and I hate that shit. I wish I could Thanos snap that shit out of existence. It's a combination product.
Does it have a corticosteroid in it?
Combination, beta-methylene dipropionate.
So stupid.
Correct, and clotrimazole. And clotrimazole is a good choice, but what happens is clotrimazole is not fungicidal. It's fungistatic. So if you just use clotrimazole alone for ringworm infection, it's fine. It stuns the thing so your body can kick it out. That's enough. But if you combine a topical steroid, the topical steroid, beta-methazole, which is potent, suppresses the local immune response and allows the fungus to migrate down hair follicles. And then
does the total opposite of what you wanted to do.
Yeah, it dominates the clotrimazole. So we finally have some studies on that in the urgent care ER literature. It says, hey, if you use this shit, people come back worse. I'm like, oh, thank God, finally. It's one of those things like in the dermatology field, we never published a study because we just accepted it as, it's just accepted as like just a normal Tuesday shit. Someone put Lotrasone on a rash and it got worse, and now I've put them on oral antifungal. So if you're allergic care and they prescribe that shit, throw it in the trash. If it got better, if you cleared with Lotrasone, it wasn't ringworm, it was nummular eczema or something like that. So we're trying to get that shit out of everybody's armamentarium, and once again, urgent care here is pretty receptive, but it's like a national problem, and so but that's, you really need to make sure your ringworm is adequately treated before you train, and it might mean staying off the mat for a couple weeks. Just as much as it sucks to not train, you got to be really scrupulous. I should look up the skin check form numbers for you, Joe. But there, in New Jersey's got a great wrestling culture. You're going to find
I'll pull it up.
Recommendations, and just post it on your wall, man. Like, as best practices for the gym. Like, look, you guys, this is the guidelines for when you can come back and train with the shit. Yeah. Everybody has to wash their belts too. Like, you got to wash your belt. Fabric harbor stuff. Wash and dry your belt. If you're a 13-year blue belt or whatever, like me, you're badass when your belt's all battered. And so just wash all your stuff. And but the drug resistant ringworm, there's a couple different pieces to that, right? You have antibiotics and antifungals all work by poisoning the target organism selectively. So you have to be able to target something that they make that we don't. And so bacteria is a little more straightforward. They're not as much like us as fungi, right? Fungi are a lot like us. Like, we've learned a lot about humans from bread.
It's fascinating.
It is. I have a PhD in microbiology. I spent years of my life studying, nerding out about fucking yeast. But My mother, you're right. But if you can invent Facebook or Twitter in your 20s, do that instead. But if you're worried about what you do in your 20s, like a PhD isn't a bad thing to do. You're advancing knowledge and you learn cool stuff. But at any rate, like antimicrobial therapy targets things that they make that we don't. It's selective poisoning. It's one of the reasons why chemo is so shitty, because it's not selective poisoning. You're trying to poison faster growing stuff more than normal stuff. So if you wonder why we haven't got a cure for cancer yet, it's because we have to figure out a way to selectively poison our own self without killing ourselves. But microbes are different. Problem with fungi is they don't have many things unique to them that we don't also have. And so there's a cholesterol in their cell membrane called ergosterol that's unique to fungi. So our drugs target synthesis of that. And so what's happening is some of the more common, we widely use antifungals, some of the more commonly present dermatophyte fungi like trichophyte rootworm, they're developing resistance to the azole antifungals and terbinafine. This shit happens. Like microbes, if you throw, yeah, exactly. And so that's one piece of it, right? You're just starting to see, like, as you would expect, over time, you throw the same drugs at the same targets, like mutations occur. You now have a selection pressure in place, and those things gradually outcompete the ones that don't die with the stuff. So that's one thing. There's a new strain that made it to the U.S. from the Indian subcontinent, Tinea endoteniae, and this one tends to be a much more severe, extensive infection, and is resistant to terbinafine. Looks like it still seems to respond to Grisea fulva, an older one, and it does appear to respond to draconazole. So it's not totally drug resistant yet, but that tends to be the problem with that one is the old school way to identify a fungus is still like growing it on a plate, agar plate, looking at the colony morphology, and it looks really cool if you like looking at colony morphologies. I can't tell you what they look like off the top of my head. I memorized this shit at one point, but problem with the Tinea endoteniae, it looks exactly like trichophyte and mentagrophytes, a very close cousin, and so it took genetic sequencing to recognize this is this is a known species, right? So it's a newly described species. But these are much more severe infections. Like, this is not like, oh, do I have ringworm? You're like, why the hell do I have a wrestling singlet of, like, it's they're gnarly. It's not.
So most likely, unless you see like you just said, a wrestling singlet of ringworm, it's most likely not this resistant strain that's causing the issue in your gym.
Yeah, and they're on the East Coast, but these are far more extensive, crazy. Like, if you have one of these, this is not subtle. You're looking in the mirror and saying, what the fuck, and you're going to urgent care, and then
okay.
But a normal ringworm infection, it doesn't look like that much. Like, might be this little patch right here. Like, I've been burned a couple of times by ringworm because it can, especially if you got a patient who has eczema, like, it might just look like normal eczema. And so I think I will continue to crap on Lotrasone for the rest of my life, but I've also told primary care docs, like, look, if you think it's eczema and you put Triam on it, you commit to a single topical steroid thinking the patient probably has eczema, which is very common, and ringworm can mimic eczema, and the diagnosis is incorrect and it's worse. Like, that's fine. I've done that. Like, you committed to a diagnosis and you picked a reasonable plan for things that can mimic. But if you're picking this other thing, which is a badly designed shit drug in the first place, the normal, not so bad, smoldery stuff that's just developed resistance over time. But ringworm can fool you, and it may be pretty subtle. But the same thing as staph. It tends to be head and neck, beard area, upper shoulders, close contact, and it could be just like a solitary patch, but like that. There's like, could be still a patch of dry skin of an itchy, so people cannot recognize that they have it. And so so it's cleaning, it's washing your stuff, it's making sure if you got a weird rash and the ringworm epidemic is not gone, you got to go get seen. You got to make sure the antifungal creams are working, and you just have to stay off the mat till you're well.
Great information. I got 2 minutes before I need to jump to another call, Doc. Which you told me not to call you doctor, so sorry, it's a habit.
Ryan Jackson, one of the founding members of the Jiu Jitsu club in Marshfield. Ryan was active reserve sniper, and he started calling me Doc. And I work also at the VA out here in the Finger Lakes. So Doc is a term of endearment among my vets.
Okay.
I'll answer Doc. It's a nickname that's comes from a place of love and acceptance, but not Dr. Green, man. Just call me Clayton. I answer Doc, though. It's one of the few nicknames that stuck to me.
Awesome. So I would love to have part 2 with you because there's so much more to talk about. But for the last 2 minutes we have here, what are some of the common mistakes you see grapplers making when it comes to their skincare or health?
I think just not washing soon enough.
How soon
And
is soon enough?
that I unfortunately don't know. And I can't find out. I don't know. I've tried to figure this out, and I don't know if I'm not interrogating PubMed correctly, but I don't have a good answer on that. I'd say just after, just go shower right
Yeah,
away.
as soon as possible.
Lather everything head to toe, and then wash. Do not reuse your towels and wash rags.
I tell people this all the time, and I think people screw this up royally.
Staph and ringworm will live on towels. That's called a fomite. So your wash rags and towels are single use, man. Take them home and throw them in the washer, and lather up. I think the fomite thing people don't recognize. There's people in my gym. There's towels that stay in the lawn in our shower. Guys, what the fuck? You guys know better. Like the grappling skin disease expert literally trains with you and never shuts the fuck up about this stuff.
I'm so glad that you never shut the fuck up about it. Please come train at my school.
I think it'll be weird if I did skin checks on all your students, but we're showered with them. That's got to be a horrible boundary violation there. But like,
we don't have showers, so that's not even an option. I wish we did. Definitely, yeah.
Don't overthink it. Pick a soap you like and use it. But if you like the tea tree does kill dermatophytes in test tubes. So that's if they want to do that, it's not going to cause a problem there. But I don't know, man. Just wash your belt and wash your towels and wash rags. Like wash all the fabric that touches your skin. It has to be a single use, washed and dried, and moisturized.
Well, thank you very much, Doc. This was a lot of fun. And I'm really serious. I would love to do part 2 because there's so much other stuff we can talk about. Let's make that happen if you're interested.
I love to. Yeah, I'd love to get it. I like this access to care, and I want to try to get this knowledge out there just so. And if anybody's listening who's an urgent care doc or a primary care doc, like you want to reach out with questions, man. I'm happy to. I don't want to sit here and crap on you because I recognize our contribution in derm to the access problem and the educational problem. So.
Maybe there's a contact email we can put in the show notes for people.
Yeah, it's just green.clayton@gmail.com. Realize if you send me pictures, I feel like I have to be very careful how I answer them because that is delivering healthcare, and I'm only licensed in New York State now. I probably should do something about that, figure out some on the side telederm practice. But right now, my answers to you are if they come off as vague, if you send me a picture, it's because if you're in Mississippi, I'm not licensed to practice medicine in Mississippi, and I have to be very careful with my medical advice if you're somewhere where I'm not licensed. It's not me being a dick. It's just the realities of modern.
Yeah, the litigious world we live in.
Uh-huh.
All right, Doc, it's a pleasure. Thank you so much.
Yeah, stay healthy out there, man.
Take care. Thank you very much to listening to BJJ Meditations. I really appreciate it. As always, if you would like to support BJJ Meditations, the best way you can do that is to book an in-person or online coaching session with me. You can do that at bjjmeditations.com. You could also make a small donation to offset production costs of this podcast. A little bit goes a long way. We don't have a ton of overhead, folks. $15 a month is what it costs to host this podcast. All the equipment is already purchased. So if you like what you're hearing, small donation is a way to get rid of that overhead. And as always, all profits, 1% of all pre-tax revenue goes toward environmental charities. Other ways to support, check out the highest levels on BJJ Mental Models Premium. Thanks once again to Steve Kwan for connecting me with Doc Green. You can sponsor BJJ Meditations if that's something that speaks to you, particularly if you work for Showy Roll or Kekawa Collective. You can email me at bjjmeditations@gmail.com. Of course, like, subscribe, review, and share wherever you are listening and watching. You can follow BJJ Meditations on Instagram. That's BJJ_meditations. Although I am increasingly spending less time there thanks to my renewed interest in Cal Newport's work. You can also read my long-form work on Substack, johanna.substack.com. And finally, come train at Princeton Brazilian Jiu Jitsu. We welcome any and all academies and affiliations so long as you have clean gi and are not a douchebag. Thanks a lot, folks, and we will see you next week.